Right, so we're very fortunate today to have a presentation by Dr. Ravi Kamapali, who many folks will know as an infectious disease physician and an epidemiologist. He has tremendous additional experience in obesity, diabetes, and wound care, has a very extensive academic and research background, and has spoken at multiple national and international conferences, as well as being actively involved in many, many clinical trials currently. He is based in Augusta, Georgia, as part of a multi-specialty practice that's focused on diabetes podiatry, on general wound care with an endocrine and vascular focus, and working on care coordination towards a comprehensive approach across the full spectrum of care delivery. So with that said, I'm going to unmute Dr. Kamapali, and if he can share his screen with us, we look forward to his presentation.
Thank you.
COVID-19 and diabetes. Ravi?
Thank you, Alan. Thank you for the introduction. I'll start sharing my screen here. Okay, share. Okay. So basically, this is going to be around 30 or 40 minute talk. I'll try to pull it quickly, but one question people ask me most of the time is, why is a infectious disease doctor involved in diabetes kind of a situation? And that's what boggled me before also. But it so happens that apart from infectious disease, I got interested in wound care and obesity medicine. And the COVID-19 kind of opened up a different pandemic scenario that made me interested in looking at it. And also I have done a few discussions on it on the YouTube channel that I have, which is on my website at nobadbugs.com. And my Twitter handle is at wound physician. And the hashtag that I use most of the time on social media is hashtag removing barriers to healing. Now, as you guys know, I'm an investor and was the founding investor in the Fruit Street Health initially. And I hope, and a lot of our friends came on board. And thank you everybody for believing that we can achieve this change. And with that said, I'll go into the presentation, and with a disclaimer saying that all this is just for educational purposes. And please have and talk and do your own research, because things are rapidly changing in this COVID scenario. So why do we have to talk about all these processes of what's going on? Where does the interaction of COVID and also current healthcare scenario happen? Is mostly in chronic medical diseases. If you see, there is like unhealthy lifestyle practices are causing 70% of these chronic diseases, and 60% of Americans are living with these chronic health conditions, according to a CDC and a RAND study that was done. And 42% of them are living with 2 or more chronic conditions. And the problem is that we have this dietary guidelines. In fact, I think in 1 week, the next dietary guidelines are going to come out. But we have to place and understand that these dietary guidelines are mostly for healthy Americans. There was a study that was done in 2009 to 2016 that showed that only 12% of the Americans were healthy, and rest of them had some significant metabolic problems. That is, 88% are not metabolically healthy. And to do that and try to reverse any disease without metabolic change and improvement is not possible. So we have to think about, yes, a recommendation that is generalized, but also that is focused at the level of N:1. That is, one size does not fit everybody. That's where the nutritional handholding with programs like diabetes prevention program will help. Now, the statistics about diabetes, of the 328 million Americans, we have around 34.2 million Americans that is who are diabetic. But what is happening is, with all this diabetic population, the problem is that some of them are getting missed and they are not being diagnosed. And Also, new cases, 1.5 million Americans are being diagnosed with new diabetes every year. And if you see that pre-diabetes in 2015, 88 million Americans are pre-diabetic. Coming to the statistics of what's going on with COVID, as of this morning, almost we are reaching the total of 2 million, 1.973 million, and total depth of 112,000. And with the opening of the country, which I think has to be done, we possibly might face dire consequences. And I think the 2-3 months that we have had this quite intimation, or we should have changed the metabolic paradigm of the country, and that could be done with telemedicine. Now, coming to the clinical context, as we know that you will see evidence in the last reference slide at the end that diabetes is associated with deficits in the cellular and humoral mechanisms of immunity. And it's associated with worsening of the outcomes with diabetes because of not just blood sugar control. We're going to talk about blood sugar control, which is very important, but we have to understand that it is insulin resistance and the hyperinsulinemia that is very important. And particularly in patients with COVID, it has been noted that the critical changes that happen because they are already insulin resistant, and these people have disproportionate burden of DKA. Now, where does the crossroads of COVID and diabetes meet is ACE2. So we need to understand, I'll talk to you a little bit about ACE2 here in a bit, but we need to understand that COVID-19 and also ACE2 are the Achilles heel of our human existence, I think, wherein ACE2 receptors increase when we have diabetes. But we need ACE2 enzyme to really help us in reducing the risk of renin-angiotensin mechanism. So we need ACE2 enzyme, but also in conditions of diabetes, hypertension, and other metabolic conditions of metabolic syndrome, the ACE2 receptors are increased. And these ACE2 receptors are everywhere in the body, mostly in the pancreas, in the nasal pathway, in the GI tract, and also endothelium. And hence the endothelial problems that we are seeing with endotheliitis and vascular issues. Coming to diabetes, what is happening is once the infection happens, there is reduction in the receptors, and hence the blood sugar control goes haywire. And also with COVID and diabetes, there is increased glycosylation. I'll explain what glycosylation is, but also there is thickening of the there is thickening of the endothelium, and the vascular perfusion and tissue health get affected. And because of increased fatty acids that are not generally from the fat that you eat, but our body is trying to protect us. So there is more fatty acids in our system in a state of insulin resistance. And that's when there is increased reactive oxygen species. And reactive oxygen species is not good for health of the person. So immune system is one that is affected the most in diabetes when there is secondary infection, because there is, as we discussed earlier, there is innate immunity that is reduced. And also there is immune dysfunction and dysregulation that is happening. And that causes reduced beta defensin production that is very much needed when there is infection. And of course, these cells that need to go through the endothelium and go to the site to protect us are kind of not able to do that. They got getting stuck in the endothelium. And when there is T helper cell 17, there is increased T helper cell 17 that causes increased inflammation. So more complications are noted in diabetes because of severity of pneumonia, as was seen. It was noted to show more than, it occurs in around 20% of the people easily in the Chinese study. But what happened with MERS, which was the earlier one in 2009, they found that diabetes was identified as a major contributor, but MERS-CoV kind of affected the DPP4 receptors, and that was the mechanism for MERS. But the routine SARS in 2005 area that we had, and also this SARS-CoV-2 are affecting the ACE2 receptor pathway. And as per the CDC and also other hospital systems, because of COVID, there's up to 50% higher problems, fatality problems with diabetes. And there is defects in innate immunity and neutrophil chemostaxis, and essentially potential higher prevalence of diabetes in our population and across the world is causing the major problem. Now, we talked about glucotoxicity. Why do we need to control blood sugar? Is not just because our body is in the presence of high glucose in the system. Then there is a condition called glucotoxicity. So we are made of proteins, but what happens is when we have sugars, normally we have 5 grams of sugars floating around in the blood, like 1 teaspoonful. But what happens is when the sugars are higher, they glycate, they join the protein and glycate, and they form something called as advanced glycation end product. So with glucose, if X times that problem is happening, with fructose, it happens 7 times. So fructose, you cannot detect fructose when you eat a fruit or too much of a fruit or a fruit juice. You cannot at that point detect fructose in the blood. So you say eat more fruits, or eat more juices. But we have to understand as physicians, as clinicians, that there is a 7-time increased activation glycation end products. So AGE are produced because of fructose. So we have to be careful when we tell people to eat more fruits. So that is a little bit anti to what is being recommended right now. So we have to also understand that when you take a glucose load, the red blood cells clump up like seen in this picture. So in neutrophilic phagocytosis, what happens is when there is increased sugar, there is increased fasting. This happens approximately 2 hours postprandially, but sometimes if you fast, there is increased phagocytosis. And this was shown in this American Journal of Clinical Nutrition. That was from 1973. So we talked about glycation. The importance of glycation is also in the innate immunity. Apart from neutrophil transfer, there is also something called as we have these cells called natural killer cells. And when we get glycation, there are 2 products that form called methyl glyoxolol and glyoxol that can cause problems with natural killer cells, and that these products then also work with the tumor. So the problem is that conjugation with the tumor, the activity of the NK cells is reduced. So problems are going to be extrapolated. And here, as you see, when there is high glucose in the cell, there is the mitochondrial dysfunctioning happening, and we are getting more of reactive oxygen species. And what happens is this high glucose induces, like I told earlier, T helper cell 17 cells. And through this reactive oxygen species, then we get TGF beta, which is one of the activation products with interleukins, and basically the TGF beta and cytokine production causes the major problem with that inflammation. So here we have one of the studies that came out in Diabetes Care that showed that in patients who are aged, suppose they checked the hemoglobin A1C, and they checked it for people who had normal hemoglobin A1C, and also in people who had diabetes when between 40 to 64 or age 65 or plus more. So this is age 65 or more, this is 45 or more, but this is The dark dot is for hemoglobin A1C. But here, in all the conditions, when there is infection, the outcomes are worse in people who have hemoglobin A1C of 10 or more. So what is happening is the more death is happening in people who who are older with diabetes with hemoglobin A1C of 10% or more. That is almost 5 times more. And also, because of this, they are three times more likely to be hospitalized. So 5 times the death and 3 times the hospitalization in people with diabetes. So that is very, very significant. And this is another study that just came out. I think it was in Diabetes Metabolism Research and Review. It's an amazing thing. I had to share this because we all know by now that in people with diabetes, there is increased interleukin-6. But what we are seeing here is there is increased neutrophil, but there is reduced lymphocyte count. So reduced T cell count. And this is exactly what happens with HIV. So there is increased inflammation, there is increased D-dimers. So, and the hemoglobin does go down. So amazingly, there's a lot of things happening that are diabetes related, and the prognosis is going to worsen with COVID-19 infection. So we have to understand one thing. This was an earlier Chinese study, I think, which showed that diabetes by itself is not shown to increase the likelihood of infection. We agree with that. But complications post-infection seem to play a huge role. But glycemic control is very much important, because even for patients who are not diabetic, after a COVID-19 infection, their glycemic control kind of goes haywire. Now, this was another retrospective study of patients with COVID-19, and they went back and looked at the hemoglobin A1C. So we have to understand why a lot of problems are happening because of multifactorial problems. We cannot focus on one thing and say, here is your solution. So the drug-bug approach has to change. So when you have high hemoglobin A1C, there is increased inflammation, there is increased hypercoagulability, and pulse ox or oxygen saturation is reduced. And it by itself has shown that with diabetes, there is 27.7% higher mortality. So we have to understand that we can increase the insulin, but only so much. The solution is not just increasing the insulin to lower the hemoglobin A1C, but also we have to understand that when we continue to increase the insulin, we might end up having problems with hypercoagulability and all these other problems that are showing up here. And also we have to focus and understand that insulin inhibits fibrinolysis and increase hypercoagulability. And the solution is sometimes to look at it in a totally different manner and likely reduce the glucose load that we are giving the patient. So this is another aspect of thinking that the food that you eat then has to become a prominent thing. So we have to closely look at what insulin is doing too, because of hypercoagulability complication and systemic inflammation. Now, so let's go back and look at what we have achieved since 2005 till 2016. And this was a JAMA article that amazingly shows something that has not happened really. If you see, the diagnosis paradigm did not change. The control levels did not improve. And blood pressure, cholesterol, all these conditions didn't change much if you see the graph here. So why is that? Are we doing any good by doing what we are doing, the status quo in diabetes care? It has to change. And I think it is changing now with the introduction of continuous glucose monitoring. And the international consensus recommendation now is to have a CGM to SS. Now, the range, the target range for that is supposed to be 70 to 180. But even with COVID, they are talking about 70 to 144. And in this, what we have to understand that when you have a hemoglobin A1C, the waveform, the glucose might be fluctuating the whole day, but when we see the hemoglobin A1C, it takes 3 months or so before we get that number. So we have to understand that intraday variability of the glucose is also very significant. So we blame the patient for not following the dietary instruction for the problems, but we have to understand that it is not just about the patient, but it is about more about the knowledge that we are imparting on the patient. Are we giving them the autonomy? Are we helping them master their own problem? Are we helping them reverse their problem or improve their problem? Are we democratizing healthcare? Is it not just about giving them an advice and hoping they follow it? I think we have to have a technology integrated high-touch solution, and this is going to be the next standard of care. So, okay. So here, in this diabetes management, there was a Lancet article that was very much important, recommending about what to do with the prevention of infection in diabetic patients, where said they asked for a like continuing the current therapy and utilization here. The recommendation of telemedicine has been prominent in that. And of course, the inpatient monitoring the pH, ketones, beta hydroxybutyrate, and all the other things that commonly we do. But we have to understand that when you give high insulin, as per the other study, sometimes we are having increased clotting problems. So we have to understand that we have to personalize a solution. And here, the therapeutic aim in this study by Lancet, for diabetes management was told to be 72 to 144. But what we have to understand is using CGM is that we have to have a target in range. So we have to keep the target in range, prevent hypoglycemia, and try to then understand that once there is infection, then we might have to keep a close eye and decide most likely to stop the metformin and SGLT2 inhibitors, because with metformin, you might end up having lactic acidosis. And with SGLT2, obviously, ketones have a basis for the positive effect of SGLT2 inhibitors. So that can worsen the ketoacidosis. There's no recommendation to change the other medications. And obviously, like I told about insulin, we need, sometimes to look at and monitor and decide what to do with the insulin therapy, how aggressive we have to be on it. So the references for this and next slide are at the end. And basically, this is a consensus report from a panel of experts in Europe. We talked about the glucose level control, but they're talking about also telemedicine. And telemedicine is going to change the world. And we at this Fruit Street, total disclosure, I'm the investor in the company, but we have imagined this in 2015, and DPP came along and we got on it. And we have to understand that we need a tighter glycemic control, like they say. And also with COVID-19, there is a new onset of diabetes. And obviously there is no change in recommendation for ACE and ARBs, but something seems to be changing with statins. When there is continued infection, they're talking about looking at statins very closely, and prompt discontinuation might be needed. But they said that sometimes there is worsening of the cytokine storm with statins, so that has to be closely looked at. Now, we're talking about metformin and SGLT2, we already discussed, and DPP4 inhibitors and insulin therapy we discussed. Here, this is very important, the diabetes and fatty liver. So most diabetics, almost I should say more than 90 to 95% do really have, like we're talking about type 2, have fatty liver. And the risk of cytokine storm is very much increased with fatty liver. And obviously with obesity, there is all the ventilator problems. And we need to understand that with SARS, and also it was noted with SARS that there is long-term metabolic complications with changes in the metabolic profile of the patients with SARS, same thing might happen with the metabolic profile with SARS-CoV-2. Also, we have to be careful and take care of the providers who have diabetes. And there was a recommendation on postponing the bariatric surgery, obviously potential risk of transmission, etc. So for further questions, there is a detailed question and answer that you can follow on ADA, and we can provide the links for that. And these next 3 slides that I will talk about is what I have seen as my summary. Basically, diabetes does suppress immune system, and there is, with COVID and diabetes, there is significant glycemic control issue. Obviously, the outpatient problems are the role of diabetologists and outpatient care therapy process for diabetes and metabolic syndrome and obesity is becoming very important because of our chronic conditions that we have in this country and across the world. 75% of healthcare problem in this country is because of chronic conditions, and the mortality is 75% related to chronic conditions. So we have to prevent this long-term burden on our health system, and we have to make sure that we educate the providers and also the patients. Obviously, hand washing and smart distancing is very important. We need to promote appropriate dietary lifestyle that is then tailored to that patient. So at the end of the day, we are talking about fat mass disease. Now, how to reduce a fat mass in a patient is needing a lot of hand-holding, apart from nutrition, apart from also the addiction part of this solution. So it has to go together. We need to promote exercise, but exercise is only 15% of what happens. So there has to be a mental health component. Obviously, communication is key. That includes telemedicine and continuous glucose monitoring, remote patient monitoring, and patient education. And safe delivery of care, of timely care is needed for acute and chronic conditions to prevent diabetes or improve the diabetes, in fact, reverse diabetes and related complications, and reduce the burden of the disease. Here we'll quickly go through if you have what is the critical components. We need to help with the lifestyle. We need to have a maintenance plan on the patient. We need to figure out mass education, but also personalize that solution. Just telling them go ahead and eat like this pyramid is not the right thing to do. And nutrition is a personal issue. There can be multiple other issues, including genetic, hormonal, microbiome, and lifestyle issues that need a lot of hand-holding. So treatment of metabolic dysfunction in our health system and across the world is needing a comprehensive approach, and that is not possible by one-on-one hand-holding. So it needs an approach wherein a lifestyle coach, a dietitian, under the physician supervision with the labs that have to be integrated, have to be brought to the patient's life flow methodology, which can be only done with telemedicine. So the last slide is the idea of how to survive and thrive in this metabolic mayhem that is going on. We can keep looking at it, or the health system and the health systems across the country need to really promote a survive and a thrive strategy with the new surge that is going to happen once the economy has opened up. We need to teach people how to self-isolate, hand hygiene, but also teach them how to fix their metabolic system, which is very much interlinked with the immune system. The target is to help immune optimization, more than augmentation, I should say optimization. I'm going to edit that slide. So, and also help with metabolic syndrome reversal. Simple steps that we can help doing that is avoid highly processed vegetable oils and foods. Now, I said highly processed because when we eat anything, it is processing. But when we are mixing many other things that we get from manufactured foods, that is a real problem. We need to promote people eating nutrient-dense food that feed our gut and also provide dense nutrition and satiety. We need to promote real foods, avoid sugary foods, and also we need to teach and handhold people to learn and listen to their body. So try to figure out what to eat, like cutting the processed carbs, prioritize protein, and fill with good fat. When to eat. So there is a lot of knowledge now out there regarding intermittent and fasting. We were not born to eat 6 times a day. There is no study proving that. The idea is we need to handhold and try to reverse that whole process of 6 times a day eating, maybe 2 times a day, 3 times a day, whatever works for the patient. And how much to eat depends upon satiation, and also try to understand that at the end of the day, calories do matter, but what and how that person's metabolism responds to what they eat is very much important. We need to help people understand that sleep is very much necessary, and sunlight exposure is necessary, stress reduction, hydration, regular exercise. Apart from that, there is evidence to say that vitamin D and vitamin C, vitamin A, zinc, B6, vitamin K2, and multivitamin of late, magnesium has also been shown to be helpful. Now, the question is, this last slide is my own understanding of how I have synthesized my own understanding into one slide that I can kind of promote as my solution to this problem. And early detection, rapid immuno-metabolic improvement strategy is the survival and thrive strategy, and we need a high-touch life flow integrated solution for that to happen. And thank you very much. I have the reference slide here, and I will also send Alan the PDF of this slide later, and also the recording will be available. I'm open for any questions you may have. Thank you very much.
So great, thank you, Ravi. That was an excellent presentation, and I think I was very impressed by the holistic approach, including involving patients in their own care, which we obviously all aim to do, but in particular how that whole approach to sort of modifying lifestyle and adjusting their sort of immunometabolic status is as critical as some of the other things that seem to be obvious to us. So the questions we had that may have been answered, I only have one typed in question so far, and if you can see that, but what does the speaker think about the GLP-1 or DPP-4 inhibitors for the control of diabetes? And then you mentioned that you'd actually answer that. So is there anything you wanted to expand on that?
No, basically, I think the GLP-1 things are helping with obesity, and obviously DPP-4 are some things that if you're depending upon the diet, suppose if you're telling people to not eat or reduce their carbohydrates, then I think those drugs don't work well. So I will let the other specialists kind of explain on that. But from an infectious disease, see, I'm an infectious disease wound care and obesity medicine specialist, and understanding the spectrum of disease process, what I want to tell is that it is not one thing like we have sold. And we can talk about other things for another time, but what I want to promote is an idea of a wholesome approach, which can only be taken when we empower the end user. And that is going to be only possible by people, process, and technology. And my knowledge is useless for the guy who is on the street unless that knowledge can be transferred and that person empowered.
Absolutely. Well, great. Well, thank you. Well, that is part of the role of these meetings, that we can actually get the expertise of folks such as yourself and disseminate that amongst the group. And we would like to be able to do that in an ongoing and more formal way as well as part of our education and training on this and many other topics. I don't see any other questions. Does anybody else have any questions they want to either type into the chat, or I can unmute anyone if they would like to ask a question. Otherwise, I think we've learned a lot today. I certainly have.
I mean, like if you have time, I can show you something.
Sure.
You're okay?
Yep,
Okay. So
absolutely.
basically, I want you guys to see this my background. So for any disease process to happen, okay, you have to have environment, lifestyle, and genetics. That's what I used to teach my patients before. And what has happened is over time, I understood that there is a lot more to it than that. And I'm trying to promote the concept of a solution that involves this concept of disease triangles in removing barriers to healing. So that can only be done with us as providers understanding that it is not just about environment and lifestyle that interact with genetics, but also a whole lot of things happen wherein, depending upon what we eat and how we live, our immune system changes and our lipid system changes. And those, in effect, turn around and influence the microbiome and the microbes that we carry, and the genes and the chromosomes. So I have a paper that I have, opinion piece that I wrote in March. Alan, I will send you that link. Maybe you can attach it with this one. So it's a piece that I kind of was frustrated with what's going on with healthcare, and as not focusing as a health system on what really augments or optimizes, I should say. We are human beings that have evolved with millions of years, and unless we harness our own immune system, that can happen by, say, when we are eating the right kind of food. There are studies showing that the T cells can improve. So when we improve our own T cells by our own food, that is food as medicine, we can survive and thrive. So that last one slide is kind of my own guide to myself when I give it to any of my patients or talk to the other providers across the globe when I talk about this process.
Absolutely. I thought that was actually a very useful slide. I don't have any great expertise in this area, but for me at least, that seemed to be a very nice synthesis of everything that you were talking about. I think we had Dr. Paramjit Dot, if I pronounced that correctly, raised his hand. I'm just going to unmute you if you have I'm trying to unmute you. You may need to do it yourself. Doing my best to unmute you.
I just wanted to ask, hello.
Yeah. Hello. Hi, Paramjit.
Hi. I just wanted to ask two questions. One is that, can you elaborate on the diet? You mentioned low carb, high protein, high fat, number one. And you mentioned a lot of vitamins, zinc and vitamin B12 and I mean, haldi has a role. And so, can you just elaborate on that, please?
Okay. Let me go back. So basically, when I said this last slide, when you say, so when you basically, when we eat anything, we need to avoid processing too much. So when we have these vegetable oils that are being sold as magic for us, all these last 50 years, what has happened is when we cook anything, we cook it in the processed seed oils. They call it vegetable oils, but in fact they are seed oils, and they are unstable. Any cooking of them kind of converts them to trans fat. That is not good. So we need to avoid that. And coming back to this simple thing, is like what to eat, when to eat, and how much to eat. So when you say what to eat, the idea is we have to understand that the core of the problem of our system as a human body is we are in a state wherein we are glucose producers or ketone makers. There are two things. when we don't produce glucose, our ketones supply our energy. But if we kind of have a problem with our liver and our liver is not doing a good job, or it became fatty liver, then our system is not able to clear the carbs, the carbs that we eat. So when we eat the carb, there is spike of insulin by 100%. When we eat protein, it is spiking only 40%. When we eat fat, the insulin spike is only like 4%, 3%. So the idea is, there is, why did I say cut carbs, prioritize protein and fill with fat, is when you prioritize protein and fat are the essential nutrients that our body needs. Whereas carbs, our body, our liver can make it. There is not need of 1 gram of carbs. Now, when I say that, people, all the flags will go up, but in reality, the red blood cells are the only ones that need the carbs, and the glucose in the spinal fluid, our body can take care of. So that is proven. In fact, as of yesterday, there was a second study, and there is multiple studies on this. I don't want to go take this discussion that way, but secondly, I will answer your next question regarding fasting and intermittent fasting. Obviously, we are not born to eat 6 times a day. When we are satiated, like we eat full, that is, see, it is all about energy toxicity. When we have a balance of energy that is more toxic. So here I'm going to, because this is a healthcare discussion and all of you guys are providers, not commoners, I want to throw in something. For us to mobilize our own fat, our insulin has to be less. I mean, like in my case, it was 18. And when I had the level come down to 5, I lost weight. So the idea is that there is 2 enzymes called hormone sensitive lipase and lipoprotein lipase. So in the presence of high insulin, hormone sensitive lipase and lipoprotein lipase are not able to act. So even though how much ever you eat the foods that satiate you, but then you're toxifying yourself and your insulin level is high and your fat is not supplying the nutrition or the energy, I should say, that is needed for you to survive. So in that state, you become hungry. You're not satiated, so you seek out food. I mean, like in my case right now, I have not eaten since 36 hours, and you don't see any low energy on me because I'm fat adapted. So that is a whole different discussion we can have another day. But now coming to vitamin D, this is one amazing vitamin which we don't promote. As providers, there is so much data that I just make it a carte blanche recommendation for my patients to take vitamin D after a loading dose of 50,000 a day, 50,000 a week for 8 weeks and 5,000 after that every day. And I myself was very low on it. And vitamin C, as you know, has been used in protocols for sepsis. And vitamin A is needed to help with mucosal integrity. Obviously, there is a lot of discussion on zinc, which is needed for patients to have an adequate zinc level. Now, zinc and magnesium that I don't have here has also been shown to be a huge issue, because in patients who are in a high insulin state, what is happening is, in a state of high insulin, we lose magnesium, we lose electrolytes. And though the serum magnesium might be kind of normal for a normal person, but the intracellular magnesium levels might be depleted. And another thing is a huge thing about vitamin K2, which when it is reduced has been shown to increase the clotting mechanism. So K1 is the coumadin acts on K1. Vitamin K2 has been shown to be a real issue, which it is available in like cheese, fermented foods, natto, and all the other natural foods that are kind of meat-based a little bit. But hopefully that answered your question.
Yes, thank you so very much. I just want small clarification about you said about fat. Fat in what form, please? That's the only clarification.
So fat. So there is different kinds of fat. You know, there is like your the saturated fat and polyunsaturated fat, and the vegetable oils that have the polyunsaturated fat, but can become trans fat too. So the idea is, when you're talking about the PUFAs, and also when you're talking about Mediterranean diet and all this, they have a lot of olive oil and a lot of whatever, so you can do avocado oil, which are similar to that. But the rest of the polyunsaturated fats is not what I like to recommend for cooking. And obviously, when it comes to the saturated fat, most saturated fats become solid in the temperate zones that we live here in US. And obviously, coconut oil, butter, and obviously the fat in animal fat, lard, and beef tallow, and all those are the saturated fats. Now, don't take this discussion and try to go to that next level. We can go into that discussion if you want about lipidology and all that, but I think with the hour will go away. So that will be a whole another discussion, because there is a controversy regarding LDL and that what happens to the LDL when you take this kind of a diet. But then we just have to go and discuss about not just one factor that happens when a chronic disease happens. So like I said earlier, it is a multifactorial problem. And we ought to understand that in healthcare delivery and make that impactful change, monitoring the data, tracking, and high-touch solution. And that is one of the reasons why I put my money where my mouth is, and I've become an investor in Fruit Street. And that's where we are right now. We just have to do the right thing, and things will happen. I wish COVID did not happen, but I guess we are in the midst of it now, and we are facing the consequences of the music of it. Now, we as a society and as providers have to take this opportunity, and maybe something good has to come out of it. We need to democratize healthcare. We need to think about healthcare delivery without walls. How can we as a system empower the end user? Put that person in the middle, build a solution around it. And hopefully, me being in Augusta, Georgia, I'm trying to work with a team here, and hopefully we'll get it done. I'll see. I mean, this is a high risk adventure for me, and I have staked my career on it, and I stake my everything on Fruit Street to them as much as possible. But I hope you guys are free to ping me on Basecamp, and also I'm free if you guys ping me and you want my cell phone number and you want me to talk more. I'm a talker. You know, I'm an infectious disease doctor. I just talk.
Thank you so very much for a really fascinating talk. I followed you thoroughly, and I'm going to be a major problem for you. I'm going to be pinging you so
often.
Problem.
No problem.
I need your cell and your mobile,
okay.
Your mobile and your email whenever you put the slides on for us. Thank you very much.
Problem.
God bless you. God bless
you. Thank you. No problem.
And by the way, I'm sitting next to you in Toronto.
Okay. Toronto, wise.
Yeah.
I don't remember Toronto.
Thank you.
Thank you.
Okay. Well, thank you so much, and thank you, Ravi. Yeah, that was excellent. I think there was only one other question that had been typed in that I think you addressed, the dose of vitamin D supported in the literature to improve immune function and increase T cells. I think you answered that.
Yeah, and I have a paper for that. I have an opinion paper that I'm going to send it to you, Alan, and then you can post it along with this one.
I'll do that. Thank you. And so, so that's a reminder to everyone. Firstly, as Dr. Kamapali said, you can ping him either directly through Basecamp if you want to share any other thoughts or get his input on anything or get materials from him. We will share this presentation and the additional materials that he has offered to share with us. And just so we know, next week the presentation will be by Dr. Maria Luz Lara Marquez, and she will be talking about the role of psychological stress on viral diseases with a focus on COVID-19. There has been a lot of talk generally in society, in the media, as well as on the Covidmd message boards on just how critical this particular topic is. So I'm certainly very much looking forward to it myself. We hope to see you there. Thank you very much again to Dr. Kamapali and to all of you for joining us, and have a great day.
Thank you.